On the topic is deep infiltrating endometriosis and nemesis is one and the same. Over to you, sir.
Yeah, thank you very much for the invitation, Jai Krishnan. I have come for at least 22 of his conferences out of 24 conferences, and I always say that my forefathers have come from Trivandrum to Karnataka, and they were the priests in Anantapadmanabha temple, and somehow they made another Anantapadmanabha temple in my place, and my generations have gone through this temple. So I just remember the forefathers who have been originating from Anantapadmanabha temple as priests. So thank you once again, Dr. Jayakrishnan, for inviting me for this. After a lovely talk by Dr. Paili, which was very, very practical, mine is not practical. It's going to be a little bit of theoretical, and people like Dr. Kurian Joseph may probably discuss with me later as to, because we find difficulty in surgeries, especially deep infiltrating endometriosis, rectovaginal septum. It's a difficult situation. So I just want to know, why is it so difficult? Why is it different from the other endometriosis? So I did a little bit of a reading. I bring greetings from Manipal University, Manipal Academy for Education from West Karnataka. Now when we look at the deep infiltrating endometriosis, deeper than 5 millimeters under the peritoneum, often takes the form of a nodular lesion, or is supposed to look like an adenomyosis, adenomatic nodule, consisting, the pathologist found that little nodule in the rectovaginal septum had a lot of smooth muscle and fibrosis with active glands and scanty stroma. So that brought a lot of these pathologists to understand a little more. After knowing about this adenomyosis, we all have read this kind of classification, how it can be focal, diffuse, and of course anywhere in the uterus. But I'm more interested in understanding a little more on the deep infiltrating endometriosis. From a histological point of view, deep rectovaginal endometriosis nodules were described as adenomyomas. We once thought it is not connected, consisting of smooth muscle hyperplasia with active glandular epithelium and scanty stroma. Dones long back, 1996, said histological pattern of deep endometriosis and uterine adenomyomas appear to be very similar. What they found recently, these pathologists who work on these ultramicroscopic structures, they found something called as pale cells. Now what are these pale cells? Though it looks theoretical, it may be connected to practice later on. Another cell population found was characterized by heterochromatic nuclei and mitochondrial and ribosomal abundance in cytoplasm. Their cytoplasm appeared more electrolucent than of the surrounding epithelial cells. Hence they are called as pale cells. They found the little kind of pale cells around the cervix. These pale cells are located in the basal endometrium, but more towards the cervix. The pale cells and their apparent ability to actively migrate into the surrounding stroma in patients with adenomyosis. The examination is conducted in various areas, and of course it is understood now that the uterus is all the time contracting, especially during menstruation, and in the midline of the uterus as shown there is a very weak portion, especially the posterior wall of the uterus going on to the cervix. Very weak portion. Whenever the uterus contracts, there is a possibility of these pale cells getting pushed into the surrounding areas, and especially the deep down in the deep infiltrating endometriosis. The specific orientation of the circular fibers of the architecture of the myometrium, called as archimyometrium, results from the fusion of two paramesonephric ducts which we knew long back, and whenever there is a fusion, the rectangle as shown there, it definitely becomes a weak portion. Hence you know that this kind of an area will push these cells into the myometrium. Now what they thought was initially, though the peristaltic pump of the uterus, which is continuously active during the menstrual cycle, is driven by the coordinated contractions of the myomuscular fibers, and the muscular distensions of the fundocornal raphe result in the formation of gaps in these areas and cause little dehiscence. So Dones once again in 2004, 20 years back, when I read this, I just couldn't believe it. I had read this as a teaching the postgraduate classes, and he said, those little nodules what you feel at the bottom there, near the cervix especially, rectovaginal septum there, is actually adenomyosis itself. So we were thinking, how is he talking about adenomyosis? Because we were always taught adenomyosis is only going from the endometrium to the myometrium and making the myometrium hyperplasia. But Donnie's thought of it long back, and now the recent ultramicroscopic picture of these kind of pale cells have come in. So they found that adenomyosis is definitely connected to hyperperistalsis and reflects an abnormal cellular behavior in favor of invasion. So the new insights of adenomyosis specifically has been because of the pale cells. The new introduction of a terminology is called as FAOM, focal adenomyosis of outer myometrium. We always thought adenomyosis goes from the basal layer little bit inside and gets into the myometrium. Now they are finding these adenomatic cells even beyond that. There will be little normal muscle and these adenomyosis is in beyond that and even beyond the cervix. That is why the pathologist said there's something new happening. It was happening before, only that they are understanding now. Focal adenomyosis of outer myometrium means specifically Chaperon et al. Said they defined uterine adenomyosis as focal adenomyosis of outer myometrium when adenomatic foci are located in the uterus, separated from an intact zone of a muscle and with preserved healthy muscular structures between the junctional zone and adenomatic lesions. Focal adenomyosis, however, was significantly associated with deep endometriosis. You very well know endoscopic surgeons like Kurian Joseph and others who are here. We know it's not easy to operate. Even adenomyoma is not easy, but sometimes it comes easily because if adenomyosis is somewhere in the peripheral part, it comes like a myoma, but we don't have a myoma capsule. That is why somebody was talking about 19-year-old girl having an adenomyomectomy in the other hall, and I was thinking 19 years had a adenomyomectomy because she had severe pain and no medication helped her. So I presume that adenomyoma was in the focal outside the basic basal endometrium. That is why they could remove that. But we know that deeper it goes, it is very, very difficult to remove. It is very hard like rock and they don't even respond to medical management. So focal adenomyosis, however, was significantly associated with deep infiltrating endometriosis. So the pale cells, rather than the whole basal endometrial gland, may migrate into the stroma of the basal endometrium and subsequently into different areas of myometrium and of course rectovaginal areas. Now interestingly what they found was, this is why I talk about theory, because tomorrow there will be an answer for this. Pale cells probably migrate actively rather than being passively translocated. It goes through and through because of uterine contraction and it doesn't go just as it is. Through the basement membrane of the basal endometrial glands. Their migration may be facilitated by the high concentration of matrix metalloproteinase called as MMP, especially 2 and 9 in the uterine fluid. Now, another word to understand is desmosome. Now, desmosomes are intercellular junctions that provide strong adhesion between the cells. Between the cells, there is something called desmosome. Now, all pale cells were found to lack the desmosomes. All these pale cells are not like other cells. They don't have this kind of desmosome. So they somehow get into different areas. Hence, invasion of the cells of the pale cells occur because of lack of desmosomes in their own cell group. So if you look at this diagram, how does endometriosis occur? And it's not just the blood getting into that area. If you look at this, the one which I've circled, basically this is a transition. A migratory phenotype changes, epithelial to mesenchymal transition. The epithelium of the endometrium gets into mesenchyme. We once thought, what is this mesenchyme, what is endometrial cells, but we know now, if the epithelium changes the mesenchyme, it is a terrible fibrotic areas. So tomorrow there can be some medication which can prevent endometriosis because this mesenchymal change will be altered. I didn't get interest initially because I happened to be in the government of India Ministry of Science and Technology for the projects from all over the country, and these are the projects coming into the Government of India Ministry, and I'm supposed to read and understand and give the opinion to the government to say whether funding should be done. I said this should fund because we will get some answer tomorrow. That means endometriosis basically is the epithelial to mesenchymal transition, and tomorrow there may be some drugs which will prevent this, and we may not be able to see that in the next 10 years. We do not know what will happen. So what is epithelial to mesenchymal transition? It's a process whereby epithelial cells are transformed to mesenchymal cells, as you see in here, and these cells are polarized and form extensive cell-to-cell adhesion. That is why all endometriosis cases with deep infiltrating situations are terribly fibrotic, all because of change into mesenchymal cells. So is there an answer for that right now? We don't have an answer, but tomorrow we might have an answer. But you should remember the change from epithelial to mesenchymal change is the answer for all these fibrotic endometriotic areas and of course deep infiltrating endometriosis. So when I just mentioned that adenomyosis can also be as a deep infiltrating endometriosis and not only in the myometrium, or because of loss of desmosomal junction, which I mentioned, is considered as a first step in epithelial to mesenchymal transition. Because I just said desmosomes in these areas are loose, and these pale cells somehow get into this junction and get all over. And once it gets all over, they change the epithelial to mesenchymal transition, and that will be the research tomorrow to reduce the mesenchymal transition and also tackle the pale cells which I mentioned. Recent experimental studies indicate that both collective cell migration and epithelial mesenchymal transitions are implicated in the pathogenesis of both adenomyosis of the uterus as well as deep infiltrating endometriosis, raising the question, are these two pathologies just different manifestations of the same disease? So deep infiltrating endometriosis has been reconsidered in the pathogenesis because of these kind of understanding of these pale cells, reconsidering because which might not be the result, we don't know, might or might not, we're not sure, but rather than the consequences, some form of cervical or uterine adenomyosis. So cervical adenomyosis can get into deep infiltrating endometriosis, and of course the lower part of uterus also can get deep into the deep infiltrating endometriosis if there is adenomyosis. So the local hyperestrogenism, increased peristalsis, tissue injury, repair, etc. are all because of uterine contractions, and they will cause increasing of these transferring of these cells. So adenomyosis is another form of inflammation like endometriosis, and impaired endometrial milieu, altered uterine contractibility are all connected to these different. So hence DIE, deep infiltrating endometriosis, is connected to focal adenomyosis. Uterocervical adenomyosis could therefore be the cause of deep endometriotic nodules, as is also the case of deep anterior endometriosis called as bladder endometriosis, and bladder endometriosis must be considered as bladder adenomyosis. Why I'm talking about that is most of these are progesterone resistant. Endometriosis and adenomyosis we know is a progesterone resistant condition. Even if they become pregnant, they can have problem. Whatever progesterone they use, it doesn't really act very well, but they have no other choice other than giving progestogens. But remember, if they don't respond to that, probably surgical intervention is important, and these kinds of deep endometriosis, you should get help of Dr. Paili sir and Dr. Korean Joseph and others who will be able to remove by knowing the structures very well. Of course, microtraumatization, tissue injury, and all these exacerbated injury by hyperperistalsis, etc. will cause invagination of these cells. So the common features are fibrosis in both conditions because of the occurrence of inflammation, angiogenesis and fibrogenesis, which are key pathological process in the progression of nodular formation in adenomyosis and adhesion in endometriosis. All types of adenomyosis and endometriosis commonly have an aspect of fibrotic disease irrespective of their localization. So when there's something like a pain, we have only few answers, so surgical management or even the medical management which doesn't work well. Of course, if it's infertility, we have no choice other than doing assisted reproductive technology. I would not like to go into details of all these kind of things, but we do not have much of medication for these kind of things. If it's not fertility, if it's terrible pain, we always start progestogens. If it doesn't work, don't go on giving for years together. You have to operate, and during operation you should know it's a nodular which is very hard there and it is not easily dissectable. It is stuck to all the neighboring organs and will be prepared for surgery as well. Dynogest is the only answer we have at the moment. Of course, GnRH analog we don't give too long because they cause bone losses, never beyond 6 months, and comparison to Dynogest is probably not so effective for a long term. However, we know adenomyosis and deep infiltrating endometriosis are primarily a disease of the uterus and constitute a single entity with a variable phenotype. To conclude, adenomyosis and endometriosis are common gynecological disorders, but their pathophysiology is still under debate. Concept of pale cells is a new idea, and the connection of adenomyosis and deep infiltrating endometriosis through this kind of infiltration of the cells. And the aim of this presentation was to just discuss whether adenomyosis and endometriosis represent two different entities or different phenotypes of a single disease. And I have said just now it's more of a theoretical discussion, but tomorrow this theory may become practice and you may get some of the different kinds of medication. At least you'll think of me at that time when some new drug has come which will change the epithelial transition to mesenchymal transition, and that will be the answer tomorrow for endometriosis and adenomyosis. Thank you very much once again.